Okay, good evening everybody. So the first thing I want to say is this talk is going to be very different from what you've had over the last few weeks. So please don't compare it to anything else. It will be different. And as Jason has said, some of what I may say may be a bit confronting or make people feel uncomfortable. I'm not going to be offended if you need to leave. That's fine. I'm not taking anything personally. Now, I was just talking to Miranda before. The first I heard that I was doing this talk was through Miranda when she said, "Oh yeah, Jason's volunteered for you to do this." I went, "Really? Better have a conversation with my husband about that." And when I did find out that I was going to be presenting, I struggled a little bit to figure out how I was going to approach this topic. And I ended up deciding that it would be best for me to put my professional hat on and tackle it from a health professional perspective. So it's important for you to understand I'm not a theologian, I'm not a counsellor, I'm not a psychologist, and I'm not a sex therapist, okay? So I'm just stating that fact right now. What I am is a pelvic health physiotherapist. And what that means is that in my professional life, I see mostly women with some men, and I see patients who have issues with bladder problems, bowel problems, prolapse issues, sexual dysfunction, pelvic pain, and I see women of all ages, from quite young all the way up to quite elderly, which includes young women, pregnant women, postnatal women, which means after you've had a baby, postmenopausal women, so there's a bit of a mix. And in my initial assessment, I ask a lot of questions, and a lot of those questions are pretty personal, including questions about sexual function. And sadly, sometimes I'm the first person that my patients have even mentioned this to, and they haven't even mentioned it to their partner or their GP. So in my role, I generally address more of the physical components, for instance, pelvic floor problems. I'm going to talk about pelvic floor in a moment, so don't stress if you think, what's the pelvic floor? But sexual dysfunction is usually more complex than just the physical components. So when assessing a patient, we use what we call a biopsychosocial framework. And what that means is we look at three components. The bio means what's happening with the body or issues in the tissues. So for instance, what's going on with the pelvic floor muscles. We look at the psychological component, the brain and the nerves, so people's beliefs, expectations, emotions, behaviours and perceptions. And then the social is the world that patient lives in. So what's their family life like? What are their stress levels like? Those kind of things. Now, I don't profess to be an expert on sex. However, it is something that I discuss with my patients a lot of the time. And my experience has been that I think a lot of my patients don't necessarily have a good understanding of their own anatomy or the physiology of sex. Now, it's important to understand that all of us come from different backgrounds and experiences that shape how we view sex. Now, you may have grown up in a family where intimacy was pretty normal and sex was openly discussed, or you may actually just ask Emily that question about our conversations around the dinner table. Or you may have grown up in a family where sex was never talked about, and if it was in quite a negative way. For some people, school sex ed and porn is their only education about sex, and sadly there are others who have experienced sexual abuse. All of these experiences shape us as people and how we respond sexually. So I thought I'd start by giving you an idea of some of the concerns that my patients have, because I don't think they're unique to just my patients. I'm going to talk a little bit about the female and male anatomy, And then I'm going to talk about 2 different models that describe sexual response and some of the differences in sexual function between individuals and some of the complexities involved. So there's 2 books that I've used while preparing for this talk. One's called The Best Sex for Life by Dr. Patricia Wirikoon. I don't know if some of you may have heard of her. She's actually a Christian sexologist. The other book, it's not a Christian book, but it was recommended reading by a sexual health physician at one of my professional conferences, and it's called Come As You Are by Emmeline Nagoski, and she's also a sexologist. Okay, so I'm just going to talk about some of the concerns that some of my patients have, and like I said, I don't think these are necessarily unique to just the patients that I see. So my first group is postnatal women. So these are women who've had a baby recently. I tend to be seeing them because they may have had some significant perineal tear as a result of the birth. And some of the... so I generally see them about 7 to 8 weeks after they've had a baby. And in my initial assessment, I tend to ask them, have you resumed sex yet? If I had $1 for every woman who said, are you kidding me? At that point, I would be quite rich by now. And often it's because they have a fear of this is going to hurt. I'm worried that I'm going to re-tear. So there's a lot of fear associated with it. Also, when women are breastfeeding, there's a lack of the hormone estrogen, and the vaginal tissues actually like estrogen, and so the tissues can be drier, which can result in discomfort with sex. They're exhausted. When you're tired, sometimes you just want to sleep. And the other thing that I notice is after women have children, their body may have changed. There are some women who have quite a traumatic birth, and it can impact them psychologically, emotionally, and just the way they feel about their body. My second group is the women who are going through or that perimenopausal stage or postmenopause, so going through or they've passed menopause. A condition called vaginal atrophy, which is again when those tissues in the vaginal tissues become thinner and drier, and there can be a lot of discomfort with sex. And by the way, there is actually a solution for that for women. There's mood changes, and again, going through those changes, how women perceive their bodies. Sometimes they feel uncomfortable about the changes that are occurring with their body. I'm often seeing these women because they've got either a bladder problem, a bowel problem, or a prolapse issue, and that can seriously impact how they feel about themselves as well. Or their partner's got erectile dysfunction, so there's a whole bunch of issues there as well. And then my third group is my patients who have pelvic pain. Now, these could be patients who just have chronic pelvic pain, so they have pain a lot of the time. And that can be for a variety of reasons, or women who they don't have pain any other time, but they only have pain if they're having sex, or if they're having a pelvic exam, or maybe if they're trying to insert a tampon. So the pain may be as a result of increased pelvic floor muscle tone, which we'll talk about in a moment. It can be at the opening of the vagina, it can be deep inside. Sometimes there's a history of sexual abuse, but not always. And it's important to understand that pain during sex is not normal and it should be investigated. I think sometimes women just put up with a lot when, it's embarrassing to talk about these things. They don't necessarily want to talk about it with their GP. And then there's my male patients who I'm usually seeing after prostate surgery because they've got leakage issues, and one of the results of prostate surgery can be erectile dysfunction as well. Okay, so that's some of my patients. I mean, even not last Thursday, the Thursday before. So in my list of patients, I had 3 women that I was seeing, all who had pain with sex. So one was quite a young woman with a history of domestic violence. Another one was a postnatal woman who had a history of painful sex. And another one was a postmenopausal woman, so she was in her 50s, long history of painful sex, and had just stopped having sex because didn't want to go there, it was too painful. So that's just in one day. Right, so we're going to talk a little bit about the anatomy. So you might have some pictures. I'm sorry if my pictures are a bit confronting as well. Our sexual organs include the genitals and the brain. Important to not forget about the brain. So in this first slide, I'm not sure if you will all be able to see that because I might be in the way, but I think in sex ed, you know, people learn about the vagina and the uterus and the ovaries and the fallopian tubes, but sometimes the vulva kind of gets left out a little bit. So that's the outer part of the female genitals, and so you can see on this, the picture on the right, and that includes the mons pubis, which is that soft tissue covering the pubic bone, the labia majora, or the outer lips, the labia minora, the inner lips, and the clitoris. There's also glands called Bartholin's glands that secrete a thin watery fluid to keep the vulva moist. Now, really important to know, vulvas are all different. If I lined everyone up in this room, I'm not going to talk about your vulva. If I lined everyone up in this room and compared your faces, they're all different, aren't they? You wouldn't expect you all to have the same face. So why is it that we expect everyone to have the same vulva? It really saddens me when I have patients who think they're not normal because maybe their labia looks different to what they think it should. I remember having a patient, and for years she had this little voice in her head from when she'd had her baby where a male midwife had told her that, oh, it's okay, surgery will fix that. I was horrified. Sometimes I point my patients in the direction of a really interesting website. It's called the Labia Library, and it shows women that there is a huge variation of what's classified as normal. And I think, for me, it's reassuring women that there is a lot of variation and that's all normal. You don't have to look, you know, a certain way. It's about, does it work? Is it functional? So, next slide. All right, this is an interesting picture, this one. So the clitoris is the female equivalent to the male penis and can vary in size between women. So if we look at this slide, so the pink bit there is the erectile tissue. So on the right-hand side, obviously, is the penis with the pink erectile tissue. And on the left is the female equivalent. And you can see how they kind of look similar. Obviously, there's differences. The male erectile tissue is just a lot more obvious, okay? So what you see or feel is only the tip of the organ. We're talking about the clitoris here. And it consists of erectile tissue that extends deep within the tissue of the vulva. And during arousal, the tissue swells and increases in size, just like the penis does. And just like the glands of the penis, the glands of the clitoris is very sensitive, and most women are sexually aroused when it is touched gently, at least to begin with. Now, really important to understand this. Less than a third of women will reliably orgasm with vaginal penetration alone, and there's not something wrong with them if they don't. I think sometimes women think, is there something wrong with me if I don't have an orgasm just with vaginal penetration? It's kind of like expecting a man to orgasm with perineal stimulation alone, and that's the area behind the scrotum that goes to the anus or the back passage. Now they might, but we're not going to say they're broken or they're not normal if they don't. Emily Nagoski says in her book, intercourse is not a very effective way to stimulate the clitoris, And clitoral stimulation is the most common way to make an orgasm happen. Okay, let's move on to the pelvic floor muscles. So next slide. Can I just have a show of hands? Who's heard about the pelvic floor muscles? Yay! Okay, that's really reassuring for me. Okay, this is what I talk about all the time. I get quite passionate about pelvic floors. So first of all, if we think about the anatomy, males have a pelvic floor as well. It's just that females, I think because we have babies, are a bit more familiar with their pelvic floors. Actually, usually only when they get pregnant. Most women don't tend to have a really good understanding of their pelvic floor before then. So normally with my patients, now you don't have to do this, but with my patients I often get them to put their hand on their pubic bone at the front and one hand on their coccyx at the back, and they notice how far apart those 2 points are. And the pelvic floor muscles run from front to back between those 2 points. And then I get them to sit on their hands and rock from side to side. And you could do this later if you want. You can feel 2 bony bits, okay? So that's part of your pelvis. And your pelvic floor also runs from side to side between those 2 bony points. So if you look at the picture, let's see. So if we look at the picture on the left, you've got a male pelvic floor and a female, and that's actually, they're more of the superficial or the outer layer of muscles. So if you're looking if somebody's standing with their legs apart and you're looking up, that's kind of the direction we're looking at, and you've removed all the skin, obviously. The picture on the right is, if you're looking down into the pelvis from above, if somebody's standing. Obviously, we've only got a female pelvis here, and you can see it kind of looks a little bit like a trampoline. So the way I describe it is it's like a trampoline with a little hole, and through the little hole pass a few openings. So in the male, there's 2 openings, and in the female, there's 3 openings. The urethra, where your wee comes out, vagina in the middle, and then your back passage at the back. And those muscles have got a few jobs to do. They control your bladder so that you stay dry when you cough and sneeze and you can get to the toilet okay. They control your bowels and allow you to hold on to wind when you want to. And they hold all your pelvic organs up, so that's kind of important. Now, sometimes these muscles can be a bit overactive, which means they're not very good at relaxing. And in women who have pain with sex, sometimes these muscles just are not very good at relaxing. So what I want you to do is think about your muscles up here in your neck, okay? In fact, just feel your muscles in your neck, okay? Now, what I want you to do is bring your shoulders up near your ears and just make them go a bit tight and feel the muscles. And now relax and let them come back down. Can you feel a difference in those muscles? Some people have a lot of tension in those muscles. I'm one of those people, actually. And if you walked around with your shoulders up near your ears all day, do you think you might get a bit sore in those muscles? Has anyone experienced pain in those muscles? Yeah. So when you're constantly in a contracted state, that can give you pain. So do you think maybe if your pelvic floor muscles are in a contracted state, they might give you pain as well? And that's what can happen. The other thing to know is the brain is really good at learning. So for some women, they may have a bad experience, and this is sadly where women who have a history of sexual abuse, it can be a problem later on for them. Even if their brain is saying, I actually want to have sex at this moment in time, their pelvic floor responds almost automatically to contract and to protect them, and that can be really painful. And the brain gets really good at just learning, when the muscles get good at learning this response, that if anything comes towards the vagina, the muscles will automatically tense and contract. So it's important, and I've said this before, it's important to understand that pain during sex is not normal and it should be investigated. Okay, so let's move on to the next slide. So this is the male anatomy. And the external genitals include the penis, the scrotum and the testes. The penis contains erectile tissue just like the clitoris, as we've talked about. And just like vulvas, penises are all different and all normal. Did you hear that? All normal? Okay. So, moving on. I'm going to talk about two different models of sexual response. Now, the first model, and if we can have the next slide, is the sexual response cycle, which describes different phases. And it's a model that's more commonly quoted, and you may be familiar with this, having different phases. So we've got desire, arousal, orgasm, and resolution. So desire meaning having an interest in engaging in sexual activity. Arousal it describes how excited or turned on you get when you anticipate or engage in sex, and it includes both subjective and physical arousal. Okay, so there's two aspects there. So physical or genital arousal refers to the physiological changes, so what's happening with the body, as in increased heart rate, blood flow, vaginal engorgement or erection. And then the subjective arousal has more to do with what you are feeling or not feeling about what your body is actually doing. So it's important to understand there's those two components. Orgasm is a release of sexual tension, and resolution is when the body returns to its normal level of functioning. Now, there are differences, however, between males and females in the way that sexual desire, arousal and orgasm are perceived and even sequenced in this sexual response. So in other words, sexual desire does not always come first, particularly in women. There's also individual variations in desire, arousal and orgasm, all within the normal range. Now, Patricia Weerakoon, she talks about the male microwave oven response versus the female slow cooker response. Now, again, that's generalising between the sexes because it's not quite as simple as that, but if, generally speaking, there is differences between men and women. So let's talk about the order of these phases. So typically, again, not always, but typically, for men, the order begins with desire. In women, it tends to be a little bit more complex, but not always. And context is important. So what is happening at that particular moment in time? So Emily Nagoski in her book states context, which is external circumstances and internal brain state, is fundamental to most women's sexual well-being. And we're going to talk a little bit about context in a while. So for women, arousal often occurs before desire. And desire can actually be thought of as either spontaneous or responsive, and both are normal. So, spontaneous desire. I guess as the word spontaneous means, it's initiating sex or wanting sex out of the blue. And it works like this for about 75% of men and 15% of women. Responsive desire, on the other hand, which means wanting sex when something erotic is already happening, that's about 5% of men and 30% of women. And all the rest, it's usually a combination of those and it's context dependent, which we're going to talk about. So, in a relationship, one partner might feel like they are the ones who always initiate sex and think, why is it always me that initiates sex? So it could just be because one person has a spontaneous desire style and the other a responsive desire style. One is not better than the other. It's just different. Now, at this point, it's important to talk about a concept called non-concordance, and that sounds like a really long word, but the idea that genital response doesn't always match mental experience. So, what's going on up here in the brain does not always match what's going on in the genitals. So, it is the relationship between the peripheral system, which is the genitals, and the central system, which is the brain and the nervous system. And the relationship between these systems is different for men and women. So men have, on average, a 50% overlap between their genital response and their subjective arousal, or what they are feeling, well, you know, in their head, in their brain. But it's a lot less in women. So the genitals tell you that's sexually relevant. The person or the brain tells you that turns me on, or I am enjoying this. So that's why it's important to pay attention to your partner's words more than what's going on with their genitals. So for example, for men, they might wake up with an erection. That doesn't necessarily mean that they're feeling sexually turned on. Or on the other hand, they might be feeling sexually turned on, but they're just not getting an erection. So there's not always, sometimes there's a mismatch between what's going on. And which is why when I'm talking to my patients, particularly my postnatal and postmenopausal women, use lube. Lube is your friend. Use lots of it. Because one thing that is going to make it really uncomfortable for women is if they're not well lubricated. So there is nothing wrong with using lube, and I tell my patients to use it all the time. Now the second model, if we go to the next slide, is called the dual control model, or model of brakes and accelerator. So this model proposes a sexual accelerator and sexual brakes. And this is a newer theoretical model of sexual response and was developed in the late 1990s. It describes not just what happens during arousal, as in what the body's doing, say erection, lubrication, etc., but also the central mechanism that governs sexual arousal, which controls how and when you respond to sexually relevant sights, sounds, sensations, and ideas. So as the name implies, there's two parts. And if you think about it, in the rest of the body, there's often an excitation system and an inhibition system in controlling different functions within the body. For instance, micturition, which is doing a wee, simplistically. It's this balance of excitation and inhibition with what's going on with the neural control. So, as the name implies, there's two parts. The sexual excitation system, or the accelerator of your sexual response. So it receives information about sexually relevant stimuli in the environment, things you see, hear, smell, touch, taste or imagine, and sends signals from the brain to the genitals to tell them, turn on. And then there's the sexual inhibition system, and this is your sexual brake. In fact, there's two different types of brakes. So imagine a foot brake and a hand brake. So one notices all the potential threats in the environment. For instance, you've got two young children and you think, I really don't want to get pregnant now. That's something that's going to be in your mind. Or my baby is going to start crying in the middle of this. And send signals saying, turn off. Think of that like a foot brake. And the other one is a bit more like a hand brake, a chronic, no-level, no thank you signal. So the foot brake is associated with fear of performance consequences, so what's going to happen as a result of this. And the hand brake is associated with fear of performance failure, like, am I going to be able to have an orgasm or not? So sexual function is about the balance between the accelerator and the brakes, and sexual arousal is about activating the accelerator and deactivating the brakes. Okay, so on average, and again I'm saying on average, men often have more sensitive accelerators and women more sensitive brakes. However, there's a lot of variation within the groups, not just between the groups. So for most people, both these systems are medium, so they're neither overly sensitive nor problematically insensitive. But some people, you know, they might have a very strong brake, for instance. Now, mood and your environment have an impact on these systems, and this is what we talk about, context. So just a few examples of maybe some brakes. So not feeling good about your body, like I talked about before, you know, some of my postnatal women who they've experienced changes to their body, they're not feeling particularly excited about those changes. Then there's, you know, another brake could be that fear of getting pregnant. Like I said, maybe the exhausted mother who's got 2 young children who really doesn't want to get pregnant just yet again. Relationship issues and a lack of trust in the relationship. I really believe that great sex relies on good trust. Tiredness is another brake. Stress, huge brake. And the environment, what's going on in the environment around you, as in, is there a crying baby in the background? So it makes sense that couples understand their individual sensitivities to these 2 systems and what might cause the brakes to be activated. So let's talk a little bit more about context. So what activates your accelerator or hits your brakes is context dependent. And women's sexuality is even more context sensitive than men's, that developmental, cultural and life history factors all profoundly shape how and when our bodies respond. And context is made up of 2 things. So circumstances of the present moment, for example, what's going on in your environment at that moment in time, and what's the brain state in the present moment. Are you relaxed? Are you stressed? Are you trusting of your partner or not? Loving or not? So I want you to think about tickling as an example. So maybe go back to your childhood with a sibling. You're mucking around, you're having fun, you're tickling each other. So your sibling's tickling you, you're laughing hysterically, and it's all fun and games. Now think about another context. Your sibling is really annoying you, has done something to really annoy you, and to annoy you even more, they decide to tickle you. Now, do you think you're going to feel the same way in both of those situations? No, you're not, are you? So it's the same sensation, but because the context is different, your perception of that sensation is different. And this also is true for sex. So what a woman wants and likes changes based on her external circumstances and her internal brain state. And that is a really useful thing for men to understand, I think. So context, really important. So what are some things that you might take away from tonight? I think the first one is understand that there is a lot of variation between individuals and it's all normal. If you are a married couple, remember your partner can't read your mind. Talk with each other. Try to understand your differences, your likes and dislikes, what activates your accelerator and your brakes. Number 3, pain with sex is not normal, and seek help if you are experiencing pain. And I will say this actually is not just for women. There are some, I haven't actually personally treated men with this, but certainly pelvic health physios do treat men with pelvic pain, and some men can have pain with sex as well. And you may want to do a little bit more reading. I know this is kind of a topic that is a topic where, generally speaking, a lot of people don't like to talk about it, or particularly if they've got issues. If you do want to do a little bit more reading and you want a Christian perspective, I'd say the one by Dr. Patricia Raccoon is probably a good place to start, The Best Sex for Life. That might be helpful for you to have a read of. So we got through. Yay. So, that's pretty much what I have to say. So I will pass it back over to Jason.